Dear friends, dear professors, we will be speaking about tic disorders and comorbidities. Comorbidity of tics and their psychopathology symptoms might be the result of shared underlying genetic factors that converge at the level of corticostriatal thalamocortical circuits. Therefore, the notion is growing that instead of viewing comorbidities as separate, these disorders should be seen as part of a spectrum of disorders with overlapping etiologies. This would be a better approach to this issue. More than one motor tic and focal tic is accompanying the Tourette's syndrome, and it's one of the neurobiologic diseases with higher genetic load. Most of Tourette syndrome individuals, the children of having TS persons have a 10% to 15% TS risk, at 20 to 29% risk of tic disorder, at 12 to 32% risk of obsessive compulsive disorder, and the 7 to 22% higher risk of chronic motor vocal tic disorder. These individuals are 10 to 100 times more risk than the general population. However, considering that the family members also share the same environment, it's not possible to prove that this disease is completely a genetic disorder. In this group, additional neuropsychiatric disorders such as OCD and attention deficit hyperactivity disorders are 10 to 25 times more common in the general population. And this supports that the hypothesis that this disease shares similar etiological factors. The most common comorbid disorders are attention disorder and hyperactivity disorder. It's reported that the ADHD combined type is more frequent with 60%. The presence of tic disorder with ADHD does not affect the symptoms of ADHD, but it also exacerbates symptoms related to tics. However, even in this case, it should be taken into consideration that ADHD diagnosis is more important for long-term dysfunction. In many cases, which are meeting to both diagnoses, we have psychopathologists. In the case of TD in community screenings, the diagnosis of ADHD was 38%. In clinical samples, ADHD was found to be 60% in children with TD and 40% in adults. This co-diagnosis is more common in men. In this case, the symptoms of attention disorder and hyperactivity disorder are usually first recognized at 3 to 5 years and occur 2 to 3 years before the tics. ADHD comorbidity increases the risk of adding other psychopathologies on tic disorders. It also worsens the course of these disorders. In a study conducted on 5,247 cases in 2015, only tic disorder TB patients in TB and ADHD cohorts were diagnosed as OCDs 1.4 times more risk, dyslexia 3.7% times, affective disorders 1.9 times, anxiety disorders 1.2 times, behavioral disorders and oppositional defiant disorder BDODD 6.1 times more, highest coefficient, sleep disturbances 1.7% more to 3 points of the anger control problems, self-harmful behavior and copropraxia are both 1.6%, and it is reported that problems related to social skills have increased 3.3 times. The most common diagnosis in the adult TB and ADHD cases were OCD and mood disorders. In these cases, anger control problems and social skill problems had continued despite that they were adults. Adult ADHD comorbidity and tic disorders in particular can be overlooked and evaluated. The tic disorders and obsessive compulsive disorder, OCD, is second among the most common peer diagnoses in tic disorders. It's generally accepted that hereditary association with tics. There are chromosome and gene anomaly studies showing that they are associated with Tourette's syndromes. There are chromosome and gene anomaly studies, as I stated.
Pons et al. Many families provide strong evidence that OCD symptoms and tics are etiologically related in families of TS, and that they can be considered as an alternative expression of the same genetic etiology. In a study consisting of 371 TS family members, the symptoms of OCD were found to be 3.2% in these individuals and 35.9% in TS. In these cases, more compulsions and on-the-spot rituals are at the foreground. This is why it's difficult to distinguish compulsions and rituals from complex tics. In addition, violent, sexual, religious, somatic obsessions, counting rituals, tic-like compulsions are frequently observed. It is It has also been reported that the OCD accompanied by tics starts earlier than pure OCD cases, shows a fluctuating but continuous course, and is more frequent in males. This association also increases the risk for other psychopathologies and also worsens the course of the tic disorder. Children with tic disorders have OCD in the presence of a partner, trichotillomania, skin cutting, pick finger temper, creaking teeth, self-mutilation, sniffling, spitting behaviors, opposite impulse phenomenon is more common. OCD diagnosis of tic disorders is also related to perinatal problems, intrauterine alcohol, nicotine, caffeine exposure. Diagnosis and symptoms of OCD in patients with TD, CM-VTD may be more important than dichotomies for dysfunction. In these cases, unlike OCD, it may not be alleviated over time. It is thought that cases with early response, accumulation and obsessive-compulsive personality without treatment are showing better outcomes. Tic disorders and aggression. In an international study, the incidence of anger control problems, aggression in individuals with tic disorders is 25%. Lifetime prevalence is 37%. Aggression in tic disorders is associated with the ADHD indications and is more reactive. In these cases, the diagnosis of ODD-BD or OCD may also be increased. However, it is thought that ADHD is important as a basis for aggression. It is reported that executive dysfunctions may predict aggression in individuals with tic disorders. In individuals with tic disorders, aggression worsens and increases the risk of additional psychopathology. Anxiety disorders are among the most common psychopathologies in children and adolescents. These disorders are most commonly associated with other anxiety disorders. The available data suggests that the prevalence of anxiety disorders is not significantly increased in children with tic disorders. In 2011, ADHD, social anxiety disorder, CAD, and OCD were found in 26%, 21%, 20%, and 19% of the children with CMVTD. In Freeman's study in 2015, children with TD have associated anxiety disorders, sleep problems, sudden emotional changes, and trichotillomania. When this data is evaluated, we can say that the systematic evaluation of anxiety disorder comorbidity in TD. Tic disorders and affective disorders. It has been reported that affective disorders, primarily major depressive disorders, MDD, and persistent repressive disorders, dysthymia in DSM-4-TR, can be frequently associated to TDs. However, these diagnoses are commonly missed. In general, it is accepted that there is an interplay between affective disorders and TDs, and both disorders may aggravate each other. Regardless of diagnosis of affective disorder, temporary subthreshold depressive state and passive suicidal thoughts may be present in periods where tics are increased. It was reported that such complaints and findings can appear as a response to sensation of failure and social challenges caused by loss of control on tics. However, each case should be assessed in details for a potential underlying affective disorder. Lifetime anxiety disorder was reported by 75%, whereas ADHD by 0 to 57% and ODD-AD by 0 to 79% in cases with association of TDs and affective disorder. Tic disorders and specific learning disorders. The prevalence of comorbid specific learning disorder is found as 22% in TDS, while its prevalence has been reported as 15 to 20% in general population. Thus, it may be suggested that TDs doesn't increase the risk for SLD specifically. Especially comorbid ADHD may mediate to SLD in seen association with the TDS. However, SLD subtypes differ when they accompany to TD TDs. Reading disorder is more common in SLD in general population, while mathematics and written expression disorders are primarily seen in SLDs in association with TDs. In individuals with TDs, social responsiveness and other communication functions can be affected in the presence of comorbid SLD, worsening prognosis. Tic disorders and self-harming behaviors. Prevalence of self-harming behavior can range from 17 to 53%. And some authors reported that self-harming behaviors are associated to motor tics, while Kulan advocated these behaviors are independent from tic severity. It has been reported that self-harming behaviors seen in TDs are independent from intelligence level, and it can be a marker for underlying depressive disorders. Obsessionality may mediate the symptom. Autism spectrum disorders. TDs frequently accompany to autism spectrum disorders, ASD, and this association unfortunately creates specific challenges in terms of diagnosis. It was suggested that tics such as hand clapping and sniffing make diagnosis. In particular, in some cases, OCD and TDs can occur during adolescence. It is emphasized that the same gene mutation may be effective in both tic disorder and autism genetic etiology. In a study conducted in 2016, the patient with 225 TS was assessed with the autism spectrum shape, and over threshold value was found in 20% of the patients. In 371 family members, this rate was evaluated as 3.2%. Mental retardation. There is a simplex relationship between the TDS and mental retardation. Whenever there is mental retardation, there is an increasing amount of tic disorders. The TD prevalence is increased in cases with MR, but vice versa isn't true. Additional challenges may be present in the diagnosis. Stereotypes are frequently seen in cases with MR. It has been reported that the diagnosis is challenging in cases where moderate to severe MR, developmental and coordination disorder, trichotillomania, substance use disorder, developmental coordination disorder accompanies to TDs, especially in the presence of comorbid ADHD and academic problems. It may increase risk for development of psychopathologies over time, and this impact may be mediated by social and academic problems. SLD and speech disorders may be seen commonly in these cases. Trichotillomania is increased in TDs. In particular, it's more common among the women with TDs and may increase risk for anxiety disorders. Substance use disorders alone don't increase risk for TDs. The group with association of TDs and ADHD are particularly at increased risk for development of substance use disorders. In these cases, it was reported substance use could aim self-medication and to control tics. It is generally accepted that the severity of tics is decreasing with age, while other accompanying disorders continue. There are studies reporting that individuals with tic disorders are more likely to report symptoms such as ADHD and OCD and lack of social support. It is speculated that late adolescents and early adulthood in particular have a risk of developing mood disorders, alcohol substance use disorders, panic disorders, and other anxiety disorders. Although DSM-5 is only recommended as a marker for OCD, other disorders may also affect the tic disorder story, response, and treatment of response. It can be said that it is important for the adult mental health and disease specialists to investigate the tic disorder story in patients, because some of the cases may not be diagnosed until adulthood. Thank you.